Good afternoon, everybody. Thank you very much for joining us today on the webinar. My name is Ash Vasireddy. I'm a consultant orthopedic trauma surgeon. I'm a 100% full-time orthopedic trauma surgeon, only fix broken bones. I operate on the pelvis and acetabulum, upper limb, lower limb, in both open and closed fractures, and also in children and adults. I work at a major trauma center in London at King's College Hospital. In addition to this, I also work in the air ambulance consultant, and also have some academic roles with some lecturer roles at the medical school. Today, my talk will be on complex fractures and the medical legal implications. And in this talk today, we'll talk about what a complex fracture is. We'll talk about major trauma centers and networks, which are a relatively new thing that have come in over the last decade, especially over the last 6 years. Also, we'll talk about what an orthopedic trauma surgeon is, and also other aspects of trauma care, such as pre-hospital care. And finally, we shall end with the medical legal implications of complex fractures. So what is a complex fracture? So a complex fracture can be determined by a variety of different definitions. There's no fixed way of doing this, but a potential way of defining it, and a way it is defined in the medical world, is the severity of the fracture. So if you look on these pictures here, you'll note that this picture on the top left is a picture of a patient's knee. There is a patellar fracture, so that's a fracture of the kneecap that you see just outlined here with the cursor. And then it's fixed in a very traditional manner with some wires and some wires which are both flexible and stiff wires to effectively repair it together. And this is a simple two-part fracture in that the fracture is composed of two large fragments. You can see here on the bottom left radiograph that this is another patient. Again, it's their knee, but here you can see the patella is much more significantly fractured. It's in multiple pieces. The shape of the patella is completely deformed and distorted compared to its usual shape. And the surgery that's needed to repair it and reduce and fix the fracture is of a whole nother level of expertise in order to achieve what's required. And as you can see here, this fracture is only really fixed with a combination of screws, a plate, and some flexible wire to bring it all back together and to make it look like a kneecap again. And so in this example, the top case is a relatively simple standard fracture, and the bottom case is regarded as a more complex fracture. Another way of defining it again would be in terms of severity of fracture. So for instance here, these are radiographs of, starting from the left, of the femur. So there's the hip obviously there, and then the femur, the thigh bone. The central radiograph again shows you another picture of a femur, and the picture on the far right is actually of a tibia. And you can see that as you go from left to right, the pattern of the fracture is different. So in this case, on the far left, the fracture is very straight. It's what we'd call a simple fracture. Again, it's not displaced too much like the patella in the previous example. However, you can begin to see now that on this radiograph here in the middle, that the fracture again is broken, but it's in multiple pieces. You can just make out some of the fragmented pieces here. These two injuries would actually be treated with effectively the same operation, which is to put an intramedullary nail, which is a long stainless steel rod or titanium rod, down the canal of the bone to realign and fix it in place. However, how that's done can be significantly different and requires, again, more expertise in the case of the middle radiograph. Here on the right radiograph, this is a tibia. It just cuts on the radiograph. You just can't see the knee or the ankle properly, but that is the tibia and that is the fibula. Again, it's a complex fracture. It's in multiple pieces. And the operation for this, again, would be an intramedullary nail. So again, a long rod going down the central portion of the bone, down the canal. And again, to fix this particular type of fracture would again require high levels of expertise and experience. And this is typically alongside the radiograph here in the middle, are injuries that we would see at a major trauma center, because they represent high energy injuries and hence you get a significant amount of fragmentation of the fracture. Another way of defining it would be to look at location of the fracture. So on the image here on the left is a reconstructed CT scan of a patient's pelvis. And you can see here multiple fracture lines within the pelvis as shown by the cursor on both the left and the right side, and also a fracture of the back of the pelvis itself. And the whole alignment of the pelvis is disturbed. This would need again, an operation typically done at a major trauma center by pelvic and acetabular surgeons, where complex surgery is undertaken with screws, specialist equipment, including specialist rods, and something called pedicle screws, which are actually instruments that we normally use in spinal surgery, but we've adapted to using pelvic surgery. And again, these operations these days are done through small incisions with image guidance, i.e. live X-ray in theatre, in order to realign and fix the pelvis. So another way of defining complex fracture is by its anatomical position. So pelvic fractures and acetabulum fractures are generally regarded as complex fractures. Another example of a complex fracture would be an open fracture. So all open fractures, again, are regarded as complex fractures. They typically occur as a result of high energy injury. They have a large complication profile with long-term risks of infection and failure to heal, in that the bone has a risk of not healing. And it also requires multiple specialty inputs from plastic surgeons and orthopedic surgeons, typically at a major trauma center. So what is a major trauma center? Well, if you go back to the beginning, back in 2010, and even prior to that in 2007, multiple organizations such as Royal College of Surgeons, in their National Confidential Inquiry into Postoperative Death in 2007, showed that significant numbers of patients who were the victims of trauma had a high mortality rate. There was also a high morbidity rate, i.e. complication rate. In 2010, the National Audit Office forensically analyzed the outcomes of these patients and found that we here in the UK, particularly in England and Wales, had a 30 to 40% increased mortality risk for major trauma patients as compared to any other Western or developed world health system. So if you compared our performance to Australia, America, or Canada, our mortality rate was 30 to 40% higher. Clearly not acceptable. So with that in mind, a number of individuals within the Department of Health, many of whom were clinicians, decided to set up major trauma centers and major trauma networks. So a major trauma center is a hospital under whose roof all specialties work. And these are specialties that are important for managing trauma patients. And some of the most important specialties are orthopedic and trauma surgeons, neurosurgeons, and obviously intensive care specialists, emergency medicine, general surgery, etc. And the key thing about major trauma centers, it was essentially ensuring that all those individuals, all those clinicians and providers who were passionate about trauma care, who had the expertise to deliver world-class trauma care, were all housed under one roof. The aim then being to take those most severely injured to those trauma centers. The network, on the other hand, was the regional area surrounding the major trauma center, which was typically regarded as the hub of the regional network. And typically, for instance, in the King's College Hospital where I work, we are the hub for the Southeast London, Kent and Medway network, whose population is approximately 5.3 million. So we're one single major trauma center for actually quite a large population area and a geographical area. Within London, there are 4 trauma centers. As I mentioned, King's already is one of them. The other trauma centers are Royal London Hospital, St Mary's and St George's. Again, all cover the corners of London and the surrounding regions. In terms of the networks themselves, they're largely based in England, just because the way the NHS is structured. Scotland operates separately and its health policies devolved, and they're in the process of setting up their own trauma networks. Wales has actually recently come online, and it is organising its own trauma network within Wales based around Swansea and Cardiff. And Northern Ireland, again, also has just come online approximately a year ago. And I was involved in some of the discussions of setting up the major trauma network in Ireland, where Belfast would be the hub. And obviously they have got a air ambulance service to house the rest of the region. There are many aspects needed to manage a major trauma system, the system being composed of its network and its hub hospitals. For that, you need good functioning trauma centers, well-functioning trauma units, which are typically the district general hospitals, and also you need well-functioning ambulance services. And these ambulance services ensure that appropriately injured patients are taken to the appropriate center. And so they have criteria in which to assess a patient at the roadside and ensure that those who are most critically injured get to the major trauma center. In addition to that, there's obviously the long-term educational and governance remits of a major trauma system, as well as its own responsibility of answering to the Department of Health and the peer review process to ensure that all trauma systems function effectively. Interestingly, just this year with the anniversary of the NHS, this tweet was sent out, and since 2010, when major trauma care became an important factor in England and with the advent of major trauma systems, it's been estimated there are approximately 300 to 500 lives a year saved as a result of the development of the trauma system. And you have to remember, this is largely due to just logistical changes. There has been some financial investment in trauma centers, but the biggest investment has been in logistics, where people have decided to move their place of work and all the relevant, passionate clinicians are housed under one roof. And then we can hopefully afford effective and efficient care for those who are critically injured. And this, as I say, has been borne out. And actually, if you go around the world now, everyone in other countries, such as America, Canada, even Europe, Australasia, do look to the UK and do kind of look to us as an example and a beacon of how to make a trauma system work. And largely, even though we were late to the party of setting up a trauma network, that's because we've learned from everyone else's mistakes. And so we were able to come online with a much more effective system, much more quickly. So the next question is, what is an orthopedic trauma surgeon? So an orthopedic trauma surgeon is typically a surgeon who only treats fractures. As you may know, most orthopedic surgeons have a mix of trauma care and elective care within their role. And what I mean by that is 50% of the time they treat patients who have fractures and broken bones. And the other 50% of the time they do elective surgery, such as total hip replacements and knee replacements. I'm only one of 2 full-time orthopedic trauma surgeons in London. And all I do is treat patients who are critically injured and who have fractures. This is a photograph of myself and my team operating on a patient who has had an open fracture of their right lower limb. And in this case, there's a plastic surgery team operating alongside me so that we can again work together in order to help improve this patient's long-term outcome. The key about many orthopedic trauma surgeons is that we tend to work on patients of any age and typically on any bone. And we also are good team leaders when necessary, and also good team players when we have to work alongside many other colleagues, such as plastic surgeons, general surgeons, anaesthetists, intensivists, and emergency medicine doctors. And the key thing about working in trauma and treating patients who are critically injured is that one really has to work with a multitude of other specialties. Whereas if you were doing a total hip replacement, the only person you really need to work with, apart from your theatre team, is the anaesthetist. Whereas when managing a trauma patient, there are often lots of discussions with other specialties, and you have to do a lot of concurrent surgical operating with other specialties in order to help treat these critically injured patients. And you have to be passionate about trauma. It's very difficult to keep going back every day into effectively a very high stress job if you're not passionate about it. The other aspects of being an orthopedic trauma surgeon are aspects around education. So for instance, I teach on a lot of national and international courses. And just for instance, last week I was in America teaching at the International Orthopaedic Trauma meeting and educating the next generation of surgeons. This photograph here on the top right, or the emblem on the top right, is of our own King's College Hospital Orthopaedic Research and Education Network, where we deliver a number of courses on trauma care and put out research into trauma surgery techniques and other protocols. The picture on the bottom right is of shock trauma. This is one of the world's best recognized trauma centers in Baltimore, Maryland in the USA, and I'm faculty there for a number of trauma-related courses. I also work in the Orthopaedic Trauma Society, and I'm a member of this group, which is an overarching association within this country that allows all of us orthopedic trauma surgeons to get together, discuss management techniques, and discuss the future of orthopedic trauma, and also educate and undertake research. And I'm also recently been awarded a national level prize by the National Institute for Health Research in order to help facilitate ongoing research in trauma care. What is happening with trauma? So trauma is just getting more common. So this is our referrals to King's College Hospital from 2017 to 2019. As you can see, there are ups and downs, and there is some seasonal variation in trauma, typically higher towards summer and slightly lower in winter. But overall, the trend is increasing. Also, we are getting increasing numbers of referrals from other districts. In the past, many district general hospitals would have operated on a number of cases themselves without necessarily referring them onwards. However, the advent of major trauma networks has now meant that a lot of critically injured patients who don't end up at a major trauma center to begin with do get transferred later on from a district general hospital. And the number of these referrals are again continuing to increase on a month-by-month basis. So pre-hospital care. So most of you, especially those of you in and around London or the surrounding home counties, and in many parts of England, will all have an air ambulance service that does look after your region. In London, we have London's Air Ambulance Service, and I was fortunate to be part of this team for the last 5 years. This is me just here, just to the right of the center of this image. So this is our 25th anniversary. And I've now worked as a consultant for Essex and Herts Air Ambulance, which is another regional ambulance service. And the role of pre-hospital care is to effectively bring the emergency department and the intensive care unit to the patient at the roadside so that you can effectively treat them and start their clinical care pathway much earlier with a long-term view of reducing their risk of mortality and morbidity and reducing their complications risk. This, for instance, was my colleagues winning the Pride of Britain Award 2 years ago for their work in helping to save Vicky's life here in the centre. She was she might be saying because she's been in the press about this recently, and has recently actually just on the English Channel with some members of this team to help raise money for London's Air Ambulance. She was a cyclist. She was working as an advertising exec, and she was actually a cyclist and had been run over by a lorry. She sustained critical injuries to her pelvis and would have succumbed at the scene. However, these two, my colleagues here as part of the air ambulance team, went to her aid and undertook some unique procedures which are at current forefront of medical innovation in order to help save her life. And as a result, now she's back at work with her family, with her friends, and enjoying life. In terms of the medical legal implications of complex fractures, there are a couple to say a few. So if you look at closed fractures, some of the common questions I ask are about time off work and protracted recoveries. So the time off work is obviously variable and does depend to greater or lesser extent on the kind of job that the individual is undertaking. So you'll find that manual workers typically need significantly more time off work, and having a 3 months or even 6 months off work is not uncommon at all, even in the case of some simple closed fractures. Protracted recoveries are very common, and largely this is due in part to the limited rehab facilities we have here in England. So I mean, just looking at it from my point of view, I always say that kind of we are very good at rebuilding someone, but sometimes the rehab is the lacking pathway. And that's currently what we as an organization are trying to fix at the moment. The rehab is the part of the pathway that does need to be significantly improved. If it were improved, I would anticipate that protracted recoveries would be less common. The other question I get asked is about long-term risks of arthritis. So post-traumatic osteoarthritis. So that is generally very common for any fractures that occur around a joint. However, there is a significant difference between what arthritic changes you can see on an X-ray versus what clinical manifestation a patient has. It's very common around some severe fractures to see early signs of arthritis on a radiograph. However, that does not always correlate with the clinical symptoms of that patient. And so one does need to ensure that when you're treating this in the long term, that you tailor the treatment. And so typically treatment may begin with removal of metalwork and some injections into a joint to see if that can help limit the pain. And obviously if things worsen and symptoms worsen, you could always think about joint fusion or joint replacement surgery. But again, the numbers of individuals receiving joint replacement or joint fusion surgery, even very severe fractures, are actually very low. There are risk factors for osteoarthritis. Obviously, there's some genetic risk factors that we cannot correct. There's obviously risk factors to do with this, with the level of the injury and how much damage there was, whether the fracture was open or a closed fracture. But overall, I think the key thing to remember is that arthritis, even after a severe injury, does not easily correlate between signs on an X-ray and what the clinical features are in a patient. And as I mentioned, in terms of how you treat it, you have to correlate the symptoms and undertake a staged approach. Rehab is always the rate limiting step, and it's always something that we encourage patients to undertake no matter where they are on their recovery pathway. You could manage symptoms both with medication and obviously activity modification, but as I mentioned, fusion and replacement surgery can sometimes be required. But again, the rates are very low. Many studies have shown that, for example, a tibial plateau fracture, so a fracture around the knee, the rate of long-term knee replacement surgery in those patient groups is typically less than 10%. So it's not a very often or not a very commonly done operation. And I think just to summarize in all, hopefully this webinar has been able to explain what a complex fracture is, and that can be defined as the severity of the fracture itself, its location, whether it's open or closed, and whether it represents a high energy injury or not. We've obviously talked about major trauma centers and how they've helped improve mortality and morbidity and how they work as part of a network. We've also talked about what an orthopedic trauma surgeon does. We've talked about aspects of pre-hospital care and some medical legal implications, which obviously you are all aware of. I think the key thing to say about why you would want to consider an orthopedic trauma surgeon for instructions is because they are dedicated to the management of critically injured patients. That's all they do. So, you know, 100% of my time in the hospital is spent managing critically injured patients, not undertaking elective surgery. So the expertise amongst orthopedic trauma surgeons, especially those working at major trauma centers, is second to none. And I think if you had victims of major trauma with high energy injuries, multiple orthopedic fractures, an orthopedic surgeon would be the right individual to help support that instruction and facilitate appropriate examination and an appropriate medical legal report. Well, thank you very much for your attention.